the balloon will definitely help us get more distal in this vessel to get a much more, I think, hopefully a more durable result. So we usually do this with two people, one person controlling the balloon and one person doing the
Okay.
injection. So I'm going to take this deflation syringe and I'm going to connect this, even though the balloon is locked, I'm going to connect it with negative suction. So what's going to happen is once we're ready to pull this balloon out, when we're done with the injection, I'm going to flip the switch. We're going to deflate the balloon and we're going to try not to drag any glue back into the base vessel, right? That's what we're going to try to do here.
This is
All
D5.
right. So Puneeth's going to flush the catheter with D5, 3 cc's. And I know we're going pretty fast here. We're going to have lots of time for discussion as we go to the other side, but we wanted to start and show you guys how we do this on one side, and then we can keep talking. This is really the only part of the procedure that I think is, a little bit nerve wracking because, you never know completely where the glue is going to go.
Can we
But
get
we've
a
done this a lot. And so
slightly bigger view there?
we feel pretty good about this location. So the key thing when you inject glue, and Puneet's done probably about 50 of these, is to go with the balloon. You don't have to go as fast, but you generally have to watch both above and below as you inject. And we're going to fluoro save this, Debbie, when you get a chance. Go a little bit faster here. So it's going through that other branch there, which is probably a pudendal or maybe a seminal vesicle branch. But see, he stopped injecting, and what we're seeing is the median lobe completely filled, and then we also see flow down through the collateral there. That's going to the penis, and so we're going to let that sort of solidify because we want that to form basically a plug. And so one of the advantages of glue, as you guys can see, is that we can fill those non-target collaterals, but not worry about small beads going distal.
Yeah, I think that's a really nice example of how with a particle, when you're injecting it, you're not going to be able to control it like this. You're not going to be able to control the flow. And even from the outset, once we were in the prostate, we're able to inject the vasodilators. We're able
What do
to
you
put
think?
up
We're
the
ready?
balloon to create a negative pressure system. We have an
Yeah, a
enormous
little bit.
amount of control here that you just don't
Yeah,
have with
maybe
a
let's.
particle. You can
I think we're good.
pre-modify again with vasodilators, with where you're injecting from. But this is such a nice example of the control that you have with glue.
So I just took the balloon down, so now we have forward flow, but the vessel's probably occluded at this point, and that's it. The other thing we could do is we could just drop a little bit of glue here just to form a little proximal plug, just a tiny bit, very slow. That's it.
And then the other thing that we're seeing here is the amount of time that you have. A lot of
You can throw
people
that away.
inject the glue and they're going to just, rip the catheter out. I mean, it really shows that with this mix, you have time to really, uh, you know, be patient and be thoughtful about how you're doing the embolization.
So that we're really happy with the way that went, and for two reasons. One is because we occluded that collateral, then you could see the pulsation from the pudendal going up, and so we were able to occlude that to prevent potentially to prevent recurrence. And we also filled the middle lobe dramatically. I'm really happy with that as well. So that was a pretty quick injection. It took about 30 seconds because we waited, but that's really the advantage of using glue. We're at 10 minutes, 10.8 minutes of fluoro time, and we're halfway done.